about catamenial epilepsy, which is just a mouthful to say. And when we say this, what do we mean? Um, so catamenial epilepsy is people who have a diagnosis of epilepsy where their seizures increase in frequency or severity at certain points in the menstrual cycle. So like Dr. DeVasta had gone over, there's these different phases of the menstrual cycle, including menstruations. That's when people have their period. The follicular phase, um, ovulation occurs here, and then the luteal phase following ovulation. And then if the person does not become pregnant, then their next cycle will begin after that. And these are how those hormone changes change over time. And some people have an increase in their seizure frequency during different points of the menstrual cycle. So I am going to pause because I know some people will be watching this asynchronously on YouTube. So I'm going to have everyone answer this question in their minds. Um, so what percentage of women with epilepsy do we think have catamenial epilepsy? So less than 20%, about 30%, about 50%, about 70%, or more than 80%. I'll just give everyone a second to think what they think. All right. So we think that this affects probably about 1 in 4 to 1 in 3 women with epilepsy. And it is a leading cause of drug resistance, meaning medications not being effective despite being appropriately chosen and at good doses. Um, so while it certainly doesn't affect everyone, it can be fairly common. There are different types of catamenial epilepsy. So remembering that it's increasing at different points in the cycle, we can have some people who have increases in their seizures around the time of their period, which is called the perimenstrual type or C1. We have some people who around the time of ovulation, which is usually for usually around day 10 to 13 is going to be that periovulatory. We'll come back to that in a second. And then we have C3, which is people who don't have ovulation. So these are things, people who, for example, have a polycystic ovarian syndrome, for example, who are not always ovulating during every cycle, or people who are adolescents who aren't ovulating every cycle when they first start having their period. And so in people who have C3 epilepsy, what happens is that rather than having this really rise in progesterone here during the luteal phase, they don't have this nice rise in the luteal phase, and they have inadequate progesterone and can have increased seizures during that phase. All this to say, we think that probably during most of these catamenial epilepsies, there's something about the progesterone to estrogen ratio, this red line to this blue line, that makes people higher risk of seizures. We used to think that progesterone was protective against seizures and estrogen was pro-convulsant. It's probably not that simple. And we know it isn't that simple, but there's something about this ratio where if your progesterone to estrogen ratio isn't high enough, the risk of seizures is somewhat higher for some people. And so notice that happens in all three of these different types of epilepsy, catamenial epilepsies. Um, so this is actually a really challenging diagnosis to make, even though it seems like it would be relatively obvious. There was a nice study that was done out of Brigham and Women's by Emma Voinescu and colleagues, where they looked at women, some of which reported that they did have a catamenial pattern, and some of which who said that, no, I didn't really see any changes in my period, my seizure frequency based on where I am in my cycle. And actually what people said, just their gut feeling, was not predictive of whether they actually had an objective catamenial pattern. So people's gut instinct wasn't necessarily that good at predicting which that they had. And so that's really important because someone may or may not be able to identify that they actually have a catamenial pattern during their visit just from an offhand gut feeling because they might not have been paying that much attention to it. The I'm going to give you three examples of how we like to sometimes track these over time, um, and how we can say if someone does or doesn't have catamenial epilepsy. These are really complicated graphs that I hope not to overwhelm everyone with. But it showed, I wanted to put them here because I think it shows how complex and rigorous this diagnosis needs to be. So for these three patients, they tracked their number of seizures that they had and the severity of seizures over the course of 3 months. So they did 3 cycles, because as we know, even though the average length of a cycle is 28 days, not everyone has 28-day cycles. Some people can have much shorter, some people can have much longer. The biggest difference usually happens during the follicular phase rather than the luteal phase, so the time between the period and ovulation, rather than the period between ovulation and the next period. It tends to be more consistent. Um, and so these three patients tracked their seizures over the period of this time. And this is how many seizures that they had on average per week during each of those cycles. And then we can graph out like the probability during each one of these phases, kind of based on how many that they had during a particular week. So during their period, during the follicular phase, during the ovulatory phase, and during the luteal phase. And this patient had reported that they did have worse seizures during their period, but when you look objectively, they actually didn't have a higher likelihood of seizures during their menstrual or during their period phase than they did during the other cycles. However, they were also asked to rate the seizure severity on a scale of 1 to 5. So for each one of those seizures, they said, like, how bad was that seizure? And so when we asked them to rate each seizure on a scale of 1 to 5, what we did see was that the severe seizures actually were more likely to happen during the period than they were during the other phases. And so what the person was noticing was not necessarily increase in seizure frequency around the time of their period, but actually there's more severe seizures. And this has treatment implications, which is why it's super important to try to figure out. And so this is the first example of how logging both frequency and severity is really important for making this diagnosis and knowing how to treat it. The second patient is a different case because when we looked at the old criteria that we used to use for this was for like 2004, they were really only having seizures around the time of their period. But when you averaged it out, it didn't actually look that different. And so there's some new criteria that were published last year, and this intuitively doesn't make sense, right? Like if someone's really only having seizures around the time of their periods, it seems like that's probably hormonally related. And so by these new criteria, we can reclassify this person as having catamenial epilepsy and a C1 pattern, meaning around the time of their period, which is really helpful because then we know how to be able to treat them. But it's why logging this is so important and helps us know exactly what's going on with someone's seizures. And then our third patient, I'm trying to remember the story of this one. Our third patient, I remember now. Our third patient really also wasn't sure. She told us, yeah, I don't really know. I sometimes may see some more series around the time of my period, but I'm not really sure. At other times it seems really bad. And so with this same system of doing a 3 month or 3 cycle log, what we found is that she really had 2 peaks to her seizures. And so even though she did have seizures during the luteal phase and during the follicular phase, her seizures were more than 2 times as likely during her perimenstrual phase and during her ovulatory phase. So around the time of ovulation and around the time of her period. And so this patient both had a C1 and a C2 pattern, which has a kind of a different implications for treatment. Because in these kinds of patients, we really want to try to see if we can suppress ovulation to try to get rid of these peaks in seizure frequency, for example, like Dr. Voss was talking about. And then this was our fourth patient. And this was a younger patient who is a younger patient who didn't report, wasn't really also sure about what her seizure frequency was throughout her cycle. This person had polycystic ovarian syndrome, so did have anovulatory cycles. But during her 3-month log, we found that she had increased seizure frequency during the luteal phase. And we were able to prove with doing serial blood tests that she did have anovulatory cycles, meaning that she was not having ovulation during her period. And so remembering that C3 epilepsy is when you have an inadequate luteal phase, it became apparent that for this particular patient, it was her inadequate luteal phase and lack of ovulation that were driving increased seizure frequency during that period. And so if you can imagine that, like, unlike for the prior patient, where suppressing ovulation could be really helpful, for this patient, it might not help that much because the problem is not really arising from the ovulation, but rather the inadequate luteal phase. And so it's why characterizing both does someone have catamenial epilepsy, and then what is their pattern that helps us to know what the best treatment is. And that's really a 3-month log that helps us to best determine that. All this to say, all of this research has been done in adults, and the amount of research that's been done in adolescents has been extremely limited. We know that adolescents do have different menstrual patterns in adults, and so what we know from the adult literature is unclear how that carries over for our adolescent population. Adolescents have rapid and variable changes in their hormone level according to adults. They're more likely to have some anovulatory cycles and irregular menstrual bleeding. The seizures themselves disrupt the HPG axis, which is super important to puberty and maybe one of the reasons why we see more delayed onset of puberty. And then there's some medications like Depakote that also impact puberty onset. So both the seizures and the Depakote could also impact our populations in terms of how they might be different than adults. And we just really don't know that very much about them. So what do we do for people who have catamenial epilepsy? As you guys saw from the previous slide, the first thing is really to know exactly what kind and how to and what kind of catamenial epilepsy someone has and if they even have it. Anti-seizure medications are still the first line treatment for catamenial epilepsy. And so it isn't that we're typically able to get someone off of anti-seizure medications through any of these hormonal treatments, which is, I think, a really important point, that if someone is having 20 seizures a day during their different cycles, and then 5 seizures a day during the other part of their cycle, probably the best thing to do is to improve their anti-seizure medication control or through other methods like epilepsy surgery or ketogenic diet. Rather than doing hormonal therapy. For patients like our second patient, though, where seizures are only happening during during parts of the cycle, or where there's this very strong association with ovulation or the luteal phase, we're often thinking about different kinds of hormonal therapies as treatment. Dr. Devassa went over some of the evidence for DMPA or Depo-Provera, but we do have a lot of other options in terms of hormonal therapies that we can use based on the type of catamenial epilepsy someone has and what it looks like. So this is a multi-center double-blind placebo-controlled trial. It's the only one that we have for catamenial epilepsy. It's from 1997, I believe. What they did is they gave women with epilepsy progesterone lozenges, and then they increased the progesterone lozenges during around the time of their period. And say we're looking at it, is increasing progesterone lozenges around the time of their period effective for all comers with catamenial epilepsy. And the 50% in responder rate was not met for this trial. But they did have a robust response in women who did have C1 epilepsy, and that makes sense, right? They were increasing the progesterone around the time of C1, people who had C1 patterns, and so they're really treating C1 epilepsy. And so the takeaway from this is that, for me, is that for some people, progesterone can be helpful but the treatment strategies really need to be individualized to the patient and the type of catamenial epilepsy they have. And there's not really a one size fits all answer to this. So these are my take-home points for this talk of that's very complex and convoluted. So I appreciate you guys paying attention to me because I know it's a lot of medical talk that's a little bit. I'm still not the best at breaking down in more common languages that I need to work on. But these are the take-home points that I think are the most important things I try to convey to people. Catamenial epilepsy is common. There's lots of different patterns that we need to try to distinguish. The diagnosis can be challenging. We need to really be tracking for at least 3 months, both seizures and the menstrual cycle, to be able to know if someone has catamenial epilepsy and what type. And in some cases, we may need to be drawing hormonal levels, particularly in people with anovulatory cycles, to know how to best to help them. And then, similar to the last talk, I think one of the most important points is particularly for adolescents who have catamenial epilepsy, there's really a dearth of evidence about how best to treat them. And so we have to really work with our families through patient-centered care and customized approaches to know how we can best meet the goals of families in terms of quality of life, side effect profiles, and trying to meet people where they are. But there's just so much that's unknown about this. So thank you. And I think that we are going to open for questions.
Wow, a third lecture of a lot of information. Thank you, thank you, thank you. I know that this information is going to go far. But yes, indeed, we're ready for questions. Who has a question?
I have a question. Can you hear me?
Yes.
I successfully unmuted myself. Wonderful. Um, so I just wanted to point out, I don't think I saw oxcarbazepine on the list of medications in terms of what interacts with bone health or contraceptives. So I wondered about that. And then, is there any concern for bone health for someone who gets their period, wants to start birth control automatically? Is that okay to start, or does the cycle have to be established for a certain period of time for any other health reasons?
I'll let Amy take the second question first while I pull up the slide about Oxcarb.
Yeah, we we see a lot of families who have so many worries about the first period or about what periods are going to be like for their children that often people want to try to start something before the first period has happened on its own. We typically recommend allowing that to occur, like letting the first period happen on its own and then seeing what that's like before we start hormonal medication. But there is no set guideline like it has, somebody has to have 3 periods or somebody has to have a year of periods or different things like that. We have no guidelines like that to say how long it has to be before then any intervention would be done.
Oxcarbazepine does affect the efficacy of birth control. We often lump it in with carbamazepine, and so like things like Esli and different kinds of you'll see like Oxtellar and these other long-acting forms. They all have a similar effect on birth control. Amy, I'm curious about your thoughts of this. Because I don't know the evidence as well as I should. I think about Oxcarb is having a moderate impact on bone health, so not as quite as much as some of our other anti-seizure medications, but not zero either.
I agree.
I have a question actually. So when I guess in the younger age we do start medicines like valproate and all, right? So when do we think about switching to safer medications for women, safer for reproduction?
It's a great question, and it's a very individualized answer. What I'll say is I certainly have patients who are of reproductive age, so 13, 14, 18, who are still on Depakote. And so I don't think it's a contraindication. For those patients, they're generally patients who have tried other medications and the other medications do not work for them, or they have a type of epilepsy where we don't have a lot of options. And so I'll give the example of juvenile absence epilepsy, for example, where we just don't have a lot of options. Or they're living in a country, because there's many countries in the world where they don't have access to many anti-seizure medications, and Depakote might be the only one of them. And so I don't think it's a contraindication. What I do think is really important is that the family and the patient be aware of the risks of Depakote should they become pregnant, and that risk benefit ratio always be talked about. And there's every visit kind of, is the risk of Depakote still less than the benefit that someone is getting out of it. And so, England has kind of it's interesting because in the UK, they now make all women with epilepsy sign this form if they're going to take Depakote. And one of the bad side effects of that is that people who maybe have a harder access to care or aren't regularly seeing epileptologists because they are doing well, then run out of medications and aren't able to get their medications. And so there's been a lot of like breakthrough seizures and bad things that have happened with these like regulatory approaches that are more negative. And then, I have some colleagues who are, for example, from South Africa, where because Depakote has now gotten this bad reputation for unreasonable in women with epilepsy, but that's one of their only medications that they have for some types. And so they have patients who are not wanting to take it. So I think as with any medication, it needs to be a nuanced approach for every patient, kind of considering the risks and benefits and making sure, which I think is one of the things that's most important personally, is that the family and the patient understands the risks, and that they understand how to manage the risks of the Depakote. We still do have some women who are pregnant who need to be on Depakote during their pregnancy, because also breakthrough seizures during pregnancy are not zero risk, right? And so I think sometimes we hear these horrible risks with Depakote and we say like, oh my gosh, I don't want that. But I do think it needs to be a little bit nuanced because it is a very effective anti-seizure medication. And for some people, they don't have a lot of other great options.
Thank you.
Hi, I had a question. Excuse me. So our granddaughter is 11. She does struggle with heavy periods and was looking into possibly talking about doing birth control. Would there be effects later on, seeing she would start so young, if it is provided to her, such as being able to get pregnant and then coming off of it? Would it be to try to get pregnant, be heavier flows and things like that? I'm sorry. My thoughts are rumbling as I'm talking.
Yeah. So for the first question, in terms of like the timing of starting something, it sounds like she's been having periods now for a little bit and they've been really heavy and difficult. And I would say we have lots of young people, particularly in this age group of being, within the first year or two after their very first period, that use hormone medications for some length of time to really control that bleeding and just improve their quality of life. Prevent having menstrual accidents, prevent having to miss so much class or feeling awkward about having to go to the bathroom all the time during school. So we have lots of people who go on different medications. And the length of time people will use those is completely individual. Like some of my patients will go on and use something for 6 to 12 months, and then they might stop and sort of watch and see what happens, have their periods improved over time as they've gotten a little bit older. Other people go on the medication and they're like, oh, this is amazing. Like, I don't want to go back to my normal period. This is fantastic. It's convenient. I'm happy. The different options we have now for controlling periods have been around long enough that we know that they do not have an impact on future fertility. Depending on what someone uses, some of those things might have different risk over time. in somebody taking an estrogen-containing pill, for example. We really don't want those people to start smoking because then we're adding another risk for a blood clot to already some existing low risk. So it's a little bit harder there to do other counseling about other longer term health issues, but we know fertility is not impacted. By the time somebody is about a year and a half after their very first period, whatever kind of pattern they have to their periods at that point is likely to keep being their typical adult pattern. So what I mean by that is like if somebody is irregular for the first year after their period, we sort of say, oh, you're young, you're developing. But if that's still happening a year and a half to 2 years after the first period, that probably means that person is going to continue to be irregular for the rest of their life. With the heavy bleeding, it's harder for us to predict whether that will continue or whether that's just related to youth and some disruptions for all of those hormonal patterns that we were talking about earlier. If there's other people in the family that have really heavy periods or bleeding issues, that might just be what her pattern is like over time.
I'm sorry, I was trying to get this to get off mute and it was not working with me. She will be 11, like I said, in December, and she started her period last December.
Yeah.
So she's about a year in. I had heavy periods. My daughters have heavy periods, so it's most likely going to be her pattern. So,
Yep. You
yeah.
can't escape your genetics. We're really good at fixing a lot of things, but none of us can escape our genetics. I'd like to be 3 inches taller. It was never going to happen.
No. She's already taller than I am, so she got that from her dad, not from her grandmother, who got it from his dad. But thank you very much. I appreciate it. The next question I did have was about the vitamins, the daily vitamins that the children take.
Yep.
Would those vitamins be in that you suggest taking the amount? Would that be in those? Would that be sufficient? Is what I'm trying to say. Sorry.
Most of the daily vitamins have about 400 units of vitamin D. And so for someone who is not vitamin D deficient, that's plenty. If we happen to check a vitamin D level and we know that someone is deficient, they probably need more than that to catch back up again. But that is usually enough to maintain a good, normal, healthy vitamin D level.
Okay. And I will say some of this helped me with my oldest granddaughter, who's 18, who struggles with a lot of cramping. So I took notes to help her. Thank you so much. I appreciate it.
Yeah, no problem. What I was going to add to your vitamin question was that a lot of child vitamins don't have folic acid in them, which is the other recommendation for people with epilepsy who are menstruating. And so sometimes when people are around, like especially 15 and 16, I'll recommend that they switch over to a women's daily multivitamin, which often does have folic acid in it. It just makes it easier to not be taking multiple things, especially if you're taking a lot of medications. And then the second thing I was going to add to your comment about your other granddaughter who's 18 is that Amy and I talk all the time in our clinic about how low people's expectations are for women's health and period issues. It's just like it seems like there's this fatalism of like there's nothing we can do about them, and people often are really having a significant impact on their quality of life, missing school, feeling miserable, and just to validate that there is lots that we can do to help people, and people don't need to suffer.
With that question, because a lot of our kids take B already due to the Keppra. And then you mentioned calcium and folic acid. And in my daughter's case, for instance, because of the winter time, we've just always kept her on 1,000 ICUs or whatever they're called each year, each month, each day. Oh my gosh, each year. You'd be like, no, Julia, that's not enough. Is it fair then that we could actually, if they have all of those in one vitamin, is there too much? I guess is what I'm trying to ask that question. Because if she's already taking this much and then we find a daily vitamin with it in it, is that going to be an issue?
As long as the vitamin D is typically under 2,000 a day, then people do not accumulate too much.
Okay.
And then with pyridoxine, it's a water-soluble vitamin, which means that people will pee it out if they're going to have too much of it. There's like very rare exceptions where people are taking like 100 times the amount of what they're supposed to be taking a day. And so there is like some people can have like peripheral nerve problems. Like they can get tingling fingers and stuff like that because they have too much B6. That's pretty rare, and you have to be taking way, 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 way more than you should. So I don't typically worry about someone taking a multivitamin and B6.
And what about magnesium? Is that something else that we should be including? And if you can't answer that, I get that too, but
Yeah. The magnesium supplements have become super popular over the last couple of years, right? People are using them now to help with their constipation, with their headaches, with their menstrual symptoms and cramping and all sorts of things. We get a lot of magnesium from our diet. It's not something that people tend to be very deficient in. I think that the supplements can be used sort of to treat symptoms, but I don't typically recommend that someone needs a daily version of that because we get enough of it in our diet. And people who get too much magnesium will get a lot of GI side effects that can be unpleasant. So we try to have people use those in a thoughtful way rather than just on a daily basis.
excellent. One other question. You mentioned the growth chart.
Mm.
That is a hot topic in our world, especially in Sturge-Weber, because sometimes they're smaller and so on. What I loved that you said, and I'm just trying to make sure I make sense of it correctly. So in Marissa's case, just because that's the one I know the best, she's always been below the chart, but it's always been growing.
Yeah.
So so it's always gone the right way, right, to go, or the other way. I guess it's flipping my hand around, but in that case, and we've done the x-rays because the pediatrician gets nervous every time they see us not on the chart anymore, or not, I shouldn't say anymore, we're just right there, but it's not quite right because we didn't grow this 3-6 month whatever that we were there. Is that, I mean, because we know that the other things are happening, maybe she's just meant to be short and tiny and little, because in my family we are. And is that something that we should be looking at too? Because it just isn't going to be that she's at the 50 percentile.
Yes, and I'm sorry if that didn't come across clear enough when I was sharing that slide. I'm looking for somebody to stay on their own curve.
Yeah.
And for some patients that we see, that isn't right on that fifth percentile or 10 percentile, but
Right.
it should still parallel the curve. It should still fluctuate and sort of go up in the same type of a way. And as long as somebody isn't pulling away farther and farther, that's what might make me take a look at things. But also taking that in context of, is weight gain progressing in a typical way? Is a young woman having periods, which we use as a marker of her body being healthy and strong and getting the nutrition that it needs? So we put together everything, but the growth chart can be one important piece of that. But if somebody's never been on the chart, I don't necessarily think they're going to be playing for the Celtics.
No. No, with that, and no, I caught that and I was almost excited and giddy because I was like, oh, finally somebody hears me. But is there, like, with some of her meds, right? Because she takes acetazolamide too, that stunts her appetite. Is there poundage that we should be looking at, or weight that we should be looking at, so that or calorie intake? Just because and here's why I'm asking this crazy question. The pediatrician said to us again, make sure that you add every fat into her because she just doesn't have a lot of weight on her or a lot of fat on her. And I get nervous when I hear things like that, just because my daughter might eat 3 candy bars for dinner if allowed. But I want her to eat the meals that, that we have, and still want her to eat enough, I guess is what I'm trying to say.
Yeah, I think that that's a situation where I often recommend families to meet with one of our fantastic nutritionists to talk about ways to incorporate healthy fats and extra calories into things you're already serving. There's nice ways to sort of bolster the caloric value of the balanced meals that you're already presenting rather than having it be like 3 Snickers for dinner. So I think that they can be really helpful with figuring out those tips and tricks to add different things to that well-rounded diet. And we look at the BMI, which is the ratio of height and weight together, to really figure out whether somebody's weight and height are appropriate for each other.
Great. Thank you.
I'd say it's
Hi.
also similar to the other
Sorry, I'm
growth
sorry.
concept we were talking
Go
about.
ahead.
Sorry, that some people are, we know that some people are naturally just larger people. Some people have very small bone structures and are skinnier. And so we have to look at multiple things, not just like any one number to know if someone's an appropriate at their right weight, right? And that's why like having nutritionists and dietitians can be so helpful because they're looking at a lot of different things and not just and just to reiterate that good nutrition is super important for epilepsy. We know that people who don't have good nutrition have more seizures and don't do as well. So very, very important to think about, but certainly just getting weight on you with Snickers bars is probably not the way to go about it.
Can I ask another question going back to the vitamin dosage? For that slide, when you looked at the importance of folic acid for fetal neurodevelopment with anti-seizure medications, what dose are you recommending? Is it a higher dose than the typical 400 micrograms? Obviously, for Depakote, it's going to be higher, but I just wondered about that because I'm a reproductive psychiatrist, and there's been a lot of talk about folic acid with Lamictal, given that it doesn't impact the folate pathway, and that there could be potential harms with high dose folic acid supplementation. I'd love to hear what you think.
Sorry, my audio went out like for 2 seconds. It just came back. My computer froze. Could you repeat? I heard something about higher folate doses, but then the rest cut.
Yeah, I was just curious what dose of folic acid you recommend during pregnancy when women are taking anti-seizure medications, because I know some medications impact the folate pathway, some do not.
Oh, yes. Okay, thank you. So this is a hot topic in women's epilepsy. Um, and I'd say that there's not fantastic consensus. It used to be that people were recommending anything from like 3 to 4 grams of folate, so 3,000 to 4,000 of folic acid for people, particularly for people who are on things like Depakote. So these very high doses. And then a paper came out that suggested that when people are taking these extremely high doses of folic acid, that there may be a slightly increased risk of blood cancers. And so now there's been this big controversy about what is the right dose. And usually we're saying anywhere between 40 and 1 gram is typically the dose that most of us will say in people who aren't pregnant. And Amy, if you can remind me, I know Emma talked about this in our talk a couple weeks ago, and I think that right now at the Brigham they're recommending anywhere from 1 to 2 grams, right?
Yes, that's my recollection also from her talk.
Okay. Okay. So one of our colleagues, Emma Boyanescu, who is a specialist in women with epilepsy who are pregnant at the Brigham, is currently recommending anywhere between 1 to 2 grams. Because when she looked at the literature, really those risks that we worry about of having very high folic acid were above 3 to 4 grams. So she's kind of typically recommending between 1 and 2.
Great, thank you.
But it's a hot topic. And I say that there's a lot of
It
controversy.
really is.
So I had another question. I am a clinical pharmacist in pediatric neurology here. So I don't think we see a lot of patients with catamenial epilepsy. I've seen only 1 or 2 cases actually. So I'm not sure if it's so hard to diagnose or it's because the incidence is low. But the kids I've seen, they're on either I guess they were on levetiracetam or phenytoin. Is that the recommended um, drug of choice, or is there like a specific medicine that works for it?
So I think in our institution, we didn't have anyone who's getting diagnosed with catamenial epilepsy until we created this clinic. And now that we've created this clinic, suddenly all of these patients are getting referred to us and like are talking to their epileptologist. And so sometimes I think that like if there's no resource that's created for something, or if people don't have the space to talk about it, people just aren't reporting it. That's my personal theory. And then for the choice of anti-seizure medication, in general for epilepsy, it really, really depends on what kind of epilepsy someone has. And so some anti-seizure medications are going to be very effective for certain types of epilepsy and others less so. Keppra is kind of, I'd say, often a first go-to because it doesn't have a lot of drug interactions. It's very easy to use. In a lot of countries in the world, it's fairly cheap. There's not a lot of insurance barriers in places like the US to getting it. So it's an easy, cheap medication that doesn't have a lot of interactions. The side effects, other than mood and behavior, are usually pretty benign, although I know that sometimes people would not say the same who've seen the behavioral exacerbations with Keppra. So, but we don't worry about things like liver failure or renal problems or those sorts of things that we worry about with some other medications. So it's often a first go-to choice for some types of epilepsy. We don't often use phenytoin as a standing medication here for epilepsy, and that's because even though it's very effective, it does have a lot of side effects typically, and it's because of the absorption with food. It's can be have a lot of variable drug levels if we're not giving it IV. And so people are
Yeah.
supposed to take it when they haven't been eating for X number of time and that amount of time. And it's just really complicated for people to like be adherent to that. And so then you can have these swinging like drug levels. And so we don't have that many patients here that are taking phenytoin. That being said, I know in a lot of the world it's a cheap, older medication that's one of the only ones that's available. And so it's probably utilized more in other places in the world.
Okay, thank you. And is it common practice for you to initiate the patient on pyridoxine as well if they're on Keppra?
Very variable depending on the epileptologist. There's not great evidence that pyridoxine helps very much with seizure behavioral changes. The evidence is not that strong. So my personal practice is if I'm starting someone on Keppra or levetiracetam, I try to, if I have the luxury of starting it slow, I do. Because I tend to see the kids having the worst behavioral side effects when we start it fast. And sometimes we don't have the luxury, right? If someone's having a lot of seizures, they really need a good drug level. Sometimes I have to start it fast. And then I try to tell people to be patient if things, as long as the child is not at risk of hurting themselves or others, which can happen with Keppra. Keppra psychosis is real, I've seen it. And so unless we're in a situation where the child is having such severe behavior that they are at risk of hurting themselves or others, I usually try to tell people to be patient for at least a week. And then if they're still having behavioral problems that are still relatively mild, meaning they're not psychotic or other things where I just say we need to come off this medication, adding B6 is not going to help. But if they're having relatively mild mood swings, behavior change, that's sometimes when I start pyridoxine. But I try to be pretty transparent with people that the level of evidence that it actually does very much is not very high, and we might be seeing a lot of placebo effect with it. Which placebo effect works about 40% of the time, right? So in about 4 in 10 patients, we can start a sugar pill and it'll help. And so it's not to say it doesn't help some people, but it's just not the best evidence. And I started usually not trying to give people multiple medications unless it's really a shared decision with the family that they want to try it. But I'd say I definitely have colleagues that start pyridoxine when they start Keppra. So it's individual practice.
Okay, okay. And when you say you start slow, you mean at like 10 mg per kg 20, or what's the
I,
range?
yeah, if I have someone who's having infrequent seizures where I have the luxury of starting slow, I usually will do 20 for 5 days, 30 mgs per kg for 5 days, and then 40 mgs per kg for 5 days and continue.
Do you have to keep them inpatient to observe, or no? Okay,
No,
thank you.
not unless someone is having, so usually, and again, it's different in every country, right?
Right, right.
Because someone's access to outpatient medical care is very different here than it would be in rural Tanzania. And so I feel like my patients, if they have a seizure at home, they probably can get to an emergency room. So I'm less likely to need to admit them. But here, the reasons why I admit someone with epilepsy is typically if they're having long seizures and they're not getting back to themselves between seizures. So I'm worried about their mental status. I'm worried about them having brain damage from long seizures. If I'm not sure if they're having seizures or not, which is a common scenario, and I really need to figure out if they're having seizures, then I might bring them in to try to characterize what kinds of seizures, are these all seizures? Um, and then really the third scenario is when I'm worried about someone's ability to access good outpatient care. And so we have some people come down to us from very rural Maine, for example, where my threshold to admit them might be lower to help them because they just live so far from a hospital, and I'm worried about sending them back out into rural Maine if they're not going to be able to get to an emergency room in time.
We usually